I think I know some of you, and maybe by name others. Pretty informal. I don't like to usually stand behind the podium because I feel like I'm preaching and I'm not as eloquent to preach, so I'm going to move over a little bit. How many of you guys actually have seen TBI patients or are involved in that? So quite a few. What I wanted to do was, like Ryan had said, I'm going to talk a little bit about identification and some management in terms of TBI patients. Very informal. If you guys have some questions, I know we're going to hold a lot till the end. Maybe I could answer them very quickly. If they're more in depth, we'll save them till the end. And hopefully this goes well with your lunches too. So, as Ryan said, I'm over at Beaumont Dearborn and Beaumont Taylor. Spend most of my time either outpatient or inpatient, and have been in the Detroit area for quite some time. Now, first of all, what we probably should do is probably define traumatic brain injury. And, it sounds fairly simple in terms of the definition, but just as a review, traumatic brain injury is basically a pathophysiological process that usually results from a blow or a jolt to the head or a penetrating head injury. That's how we think of it. Now, you can get other pathologies, such as bleeds or hemorrhages, that also are classified as traumatic brain injuries as well, or aneurysm ruptures and so on. Now, it's important to realize that not all the blows or the jolts to the head are going to result in a TBI. Obviously, you bump your head, doesn't mean you have a TBI. But there are those even pediatric patients or children that have a fall, may have had a confusion episode, and we label it as concussion. Concussion is also classified as a traumatic brain injury. Okay? Now, in terms of severity, the general terms we've traditionally used is mild, moderate, and severe. I'm going to try to go over some of the guidelines a little bit for you guys, so it kind of helps you when you're looking at either the patient or the documentation to understand how we came to that diagnosis. Okay? In terms of epidemiology, as you can see, and the triangle actually shows it fairly well, right here, that basically if we were to look at all the data, and even as far back as 2000, 1995, so on and so forth, they found that there are quite a bit of traumatic brain injury patients. And the triangle does indicate that really we don't really know how many are out there. Some patients will see specialists like myself or Dr. Ferris. Some will go on to their primary care physician. Some may even go to the urgent care center or the ER and then get sent home. And some may not even be seen if the parents or individuals feel that they're okay. So we really don't know. In terms of the ones that do go to the ER, 2.2 million visits for head injury. So that's quite a bit. So we do need to have some type of knowledge base or exposure on what is a head injury and what's not. Of those, approximately 283,000, or if you really look at it, 10% will get hospitalized for it, and of those, you're going to have 20% actually go on and have death. Now, of the ones that don't die, obviously, there's a continuum of how severe they're going to be, mild, moderate, or severe. Now, in terms of costs, now how many of you guys are case managers? Okay, how many of you are clinicians? Okay, how many of you are both? So you can see that, obviously as a clinician as well as case management and someone looking at the care for a TBI patient, costs are going to be something that we really have to look at. And if you were just to look, you can go ahead and read this, and this will tell you in terms of $1985 the cost, basically $4.5 billion in direct costs and $20.6 billion in morbidity costs at that time. Now, in terms of 2006, you can see that it ballooned up to $11.5 billion in direct and $64 billion in indirect. So quite a cottage industry. In terms of risk factors, and this may be review for most of you or all of you, essentially younger, Demographics, poor, unmarried, minority, inner city men usually are more likely to have traumatic brain injury. In terms of incidence, males 2 to 1 over females in all the age groups, and the most common is 15 to 24. Okay? Greg, there's no quiz or anything on the end, is there? Okay. Just want to make sure. We could. Now, the pie chart really does show nicely the breakdown in terms of the different causes. And you can see falls, motor vehicle accidents, as well as struck by or against or other trauma and assault are by far the majority of cases that we do see. Now, I'm not going to go over the specific numbers because this is old data and it does change and it's looked at annually. It's actually looked at by the CDC every year. Okay? Plus, I have a little time segment I have to make sure I fit in. So, in terms of pathophysiology, there's a primary injury, secondary injury. Primary injury is immediately after the time of impact, and basically you get acceleration, deceleration type of forces, either focal or diffuse, and then secondary pathway after that results into other kinds of findings. So just because someone has had an impact at a moment or at some time doesn't mean they're going to show symptoms right away. And that's really the key point I want you to take away from this. Patients will at times not display any types of pathology until later. And it can vary. It can vary to in a day or so, a couple hours, or even weeks, or sometimes even months in some of the subacute types of pathologies. This is just for your knowledge base, but you can see pathway in terms of primary can either be focal or diffuse, and then we go through the different physiological changes for a head injury. I think for most of you, you don't need to know this, but realize that when we do the workup, these are the things that we're looking for as physicians. We're looking at what are the primary causes, what are the things that we can look for primarily, and then also secondary to help define really what happened. Primary injuries, just for, again, completeness, can range from skull fractures to auditory and vestibular dysfunctions to hemorrhages, contusions, diffuse axonal injury. How many of you guys have actually seen that in documentation? Not, yeah, some. And you may see it. Basically refers to a generalized pattern of injury in the brain and does become, a traumatic brain injury. It's really a hallmark of TBI, as well as penetrating injuries. Secondary injuries, we can get neurochemical and cellular changes, edema, pressure, hydrocephalus, as well as herniation of the brain. And those things you may see in the documentation that you see, and that kind of should help point you to, well, there may be a traumatic brain injury or there may be something going on that's evolving. Okay, now, team approach to care. Obviously, a full team involved. Neurosurgery, general, ER, ortho, neurology, PM&R, of course, internal medicine, family medicine, nursing, and therapy. So all these pieces of documentation are very important to look at what the care pattern is for these types of patients. So once you've identified the patient as a traumatic brain injury, these pieces of information should then help you really assess to what the severity level is, as well as what type of care is going to be needed. And someone who's trained in brain injury medicine is usually fairly specific in terms of those needs. So if there's questions, obviously these specialists should be able to answer those in relation to the injury. Again, just a slide to illustrate the continuum involved. When you guys go through the notes or clinically involved in care, you're going to see aspects from all these levels of care in terms of your patient. Now, the initial assessment, the things that we look for as physicians, obviously after the injury, it is dynamic, so we have to make sure that we assess them regularly. The most things to look at, especially through your documentation or ER notes, is that there are assessments done periodically to look for changes. So that's one aspect. Number two, a comprehensive initial examination, as well as we talked about serial assessment, also history, clinical exam, labs, and imaging studies. Okay? Now, all those pieces of information will then help determine which level of severity that they're going to fall into. If they're very severe, then there is going to be indication for admission. And that obviously will depend on their level of consciousness. A lot of patients will come in through the ER, get discharged within 24 hours because there's no evolution or no change. That does not mean that we're done with the assessment. Typically for our center, patient will come in, we'll evaluate them, we'll get the imaging, and if they're safe for discharge, we'll discharge them. But then in 1 week, we will follow them up in a concussion clinic. So that documentation is important also. And it's important not to stop at the ER note that says, okay, they're discharged and we're done with that care, okay? Now, this is just for completeness, so I'm gonna gloss over it, but TBI in children obviously are something that you have to think about. How many of you guys do PEDS management? PEDS, I guess the message from this slide, if you were to read all the different types of things that you can see in a TBI patient that's a pediatric patient, it's hard to tell whether they're just in a bad mood or they've got a TBI. And I'm sure I know some adults that fall into the same category. So you never know. Severity scales, the ones that we typically use acutely, we use what we call the Glasgow Coma scale initially, and that's usually done at a couple points in the evaluation. It should be done at the initial site of assessment, so if an EMT goes and assesses a patient, they'll probably have a score. Once they come through the ER or a trauma center, they will be scored again. And then shortly thereafter, they will be scored again. And that's important because it will help you determine where they may fall in the severity level. And again, the range is 13 to 15 for mild, 9 to 12 for moderate, 3 to 8 for severe. Now we also look at in terms of their altered consciousness level. Is it less than or equal to 24 hours or greater? Their loss of consciousness, is it 30 minutes or more or 24 hours? Also in terms of their post-traumatic amnesia. And that will help with also falling into concussion levels. So we do look at all those aspects as well. So in your review or your follow-up, it is important to look for these pieces of information because they will again help you in determining what level of care may be warranted after their initial assessment. Now the Coma scale, kind of put it up here, and again, I don't think you need to memorize it, but if you can see part of it anyway. Basically, it's broken down into 3 different aspects. And there we go. Motor, verbal, and the eye opening. I'm trying to phase it in and out as best that we can. I don't have a TBI. I'm just going with the flow. So motor response, we grade it, and obviously ranges from 6 to 1. Verbal goes from 5 to 1, and 3 to 1. As you can see, the sum really is the GCS score. So can we get a 0 on a GCS? No. Base score is 1 on all of these, so minimal score is going to be a 3. Okay? This just breaks it down even further. In terms of post-stabilization levels or care that they're going to require, the research has shown that mild, obviously 13 to 15, moderate at 9 to 12, and that's where you have loss of consciousness, would benefit from rehab. A severe disability we consider 3 to 8, and that can be even coma or unconscious state. And although this says vegetative state less than 3, we don't hit less than 3. Okay? So this kind of gives you a little guide in terms of the levels and what to expect on their examination or evaluation. Again, general evaluation. Each patient is very different, and you need to look at that specific, individually. Other scores that you might see in the documentation, the Ranchos Los Amigos scale, and basically that has to do in terms of their response to the clinician, and it's broken down from level 1 through level 8, and basically has to do with whether they're purposeful, automatic, or are they confused and agitated or inappropriate. And again, this is for completeness. I don't always see clinicians use this in rehab. Some will use it, some won't, but it's important to be familiar with because it will help you determine in terms of what type of rehab program they may require, depending on the level. Neurological exam, again, for identification, very important. Make sure that there is a neurological exam in the documentation that you do review or do, because really that's going to be the hallmark of your whole management process. If you know what they're neurologically at, that's going to tell you how much help they're going to need or what kind of care they're going to need. And I have included a couple of anatomical things. So cranial nerves, that's part of the neurological exam. No quiz, so we don't have to memorize this. There's 12 of cranial nerves, and as a medical student, I use mnemonics to do it. I'm sure nursing, same thing. Testing, imaging includes CT, MRI, EEG, PET, and sometimes ENG or vestibular. CT advantages, obviously, done very quickly, X-ray based, and you can look for bleeds right away. Those are the ones that we do right away in the ER, make sure there's no bleed. Obviously, there are some minuses, and that has to do with it's only a structural test. Doesn't really tell you anything physiologically. MRI, much more information. You look at soft tissue very well, but it is better for the parenchymal lesions, or really lesions in the brain, not so much for bleeding. We use it as a follow-up if we can't do that. Find things with the CT. Minuses, it's a tube, it's a magnet. If they've got metal, you can't utilize it, or a pacemaker. So there are limitations for that as well. EEG, this is an image actually of a 3D EEG, and basically it's through the continuum. But EEG is a physiological test, does not look at structure whatsoever, looks at brain activity. Very good for seizure assessment or looking for abnormal activity or regions of abnormal activity. But again, won't tell you anything about what things look like. PET, how many of you guys have seen PET scan information? So one. PET scan, mostly research-based, but very helpful in terms of looking for metabolic changes or physiological changes. Another thing that you may see instead of PET scan is called a SPECT scan. Differences, PET scans traditionally are at university centers. SPECTs are more at the community hospitals. Single photon versus a positron type of image, but really looks at the activity of the brain. And really looks, this image, for example, looks at the sugar uptake in the brain and the different areas that have uptake. Brain injury patients do have changes, so that's why we do utilize that as well, and you may see that requested or ordered. And as you can see here, here's an image of a normal glucose uptake study, PET study. One with a severe traumatic brain injury. You can see quite a bit of decrease in terms of uptake in a lot of regions. And in a concussion even, you can get the same kind of pattern. So it's important to know or be familiar with that these tests are done. That will help you in terms of determining how severe patients will be as well. Coup, counter-coup injuries, those are the most common, obviously. Has to do with coup, direct area of impact, counter-coup, indirect. And how many of you guys see patients with whiplash and things like that? So we can get those kinds of findings in those patients as well. Again, the physician should be able to help identify that and help you through looking at the documentation. Now, the rest of this is all in terms of areas. I'm going to gloss through it because it's very detailed, but the different areas that we look at as clinicians, obviously we want to see, is there injury to the cerebellum? There are things that we look at in terms of function and signs. These are important to know. And do they have access to the slides if they need it? We could. Okay. So, you know, if you're bored at night and you got to get to sleep, good bedtime reading for you. But this really helps in terms of what areas that we want to focus on in terms of the neurological exam. So cerebellum, we look at in terms of pathology, midbrain, as well as the pons or the pontine area. And again, we're looking at cranial nerves, we're looking at balance, we're looking at respiratory function and those things. Pontine again, injury to the medulla oblongata, and obviously mild TBI. I want to just touch on it. I know Dr. Ferris is going to go more into detail of other treatments and things. Most prevalent type of TBI, so that's what you're going to probably see the most. And of those, a lot of them are missed at the initial injury. It brings a story. How many of you guys are Michigan fans since it's Michigan State week? I'm a graduate of both, so I can, my heart bleeds blue, but I pay green. So it comes to mind there was an incident on the field with coach where there was a patient who had a head injury, was not identified, and I don't know if you guys remember the game. This was with Brady Hoke. Did not pull the player off the sidelines. Obviously got in a lot of trouble for that. But those are kinds of things that sometimes if it's not identified, it can lead to worsening in terms of symptoms and severity. So very important that if it's not identified at an initial event, make sure you follow up or look for the documentation that there was follow-up. Now basically it's defined as a result of forceful motion with the head or impact causing a change in consciousness. Again, it could be brief, it could be a persistent loss of consciousness, or even a transient feeling of dizziness or haziness as well. Now, other names that we'll see with mild TBI, obviously concussion, minor head trauma, minor TBI, minor brain injury, or minor head injury. So look out for those terms because that will help you in terms of looking to see if there's something that's being thought of for the patient. Common symptoms of mild TBI, again, as you can see, fatigue, headaches, visual disturbances, memory loss, poor attention, sleep, dizziness, feelings of depression and seizures. How many of you guys have these regularly? I do. And so you can see they're very vague, and sometimes looking for just the symptoms is not enough, but the clinical examination should help at least tease that information out. And if you guys don't see it, I would definitely encourage you guys to call the clinician or contact them and say, how was the neurological exam? Okay? Other symptoms, nausea, loss of smell, sensitivity to lights and sounds, mood changes, getting lost or confused, slowness of thinking. Again, migraines can also be defined as these things. So make sure that those things are evaluated for as well and that they're not confused with a head injury. Okay? PTSD, how many of you guys see PTSD documentation? And you can see there is a little crossover in terms of that. And again, very vague in terms of symptomatology. Make sure it's looked at because it can definitely indicate a certain level of severity for the head injury patient. Now, program-wise, again, it'll be real brief. Goals are going to be to stabilize as well as restore and analyze at the same time. And Dr. Ferris is going to go over treatments. So, questions? Did I make it in time? Okay, good. Questions?
We have time for questions.
How do you know between a TBI when a patient has a pre-existing condition for Alzheimer's?
It's a challenge.
Yeah, it is.
It's a big challenge. Part of it will depend on if there is an established relationship with the patient and you know the symptoms from before and after, then it's easier to do. If it's a new patient, like for example, someone who comes to see me that does have a history in the past and now has these new symptoms, what you have to do is you have to correlate all your findings, not only your physical examination, but also in terms of what the imaging showed, if there's a certain region affected, neuropsychological testing as well to look for deficits. Alzheimer's has a certain pattern, and it tends to be more generalized in terms of presentation. Something more focalized tends to be more indicative of a TBI. But you still got to go through the process.
Doctor, do you often run into patients, I noticed on your last slide you were showing about mild TBI. A patient gets in a car accident 6 months ago, and obviously was impacted, but walked away from it, and didn't think they had a problem. And then all of a sudden, it seems like things manifest themselves over the duration of time to a point where 6 months later, I was looking at the slide and I noticed a lot of symptoms that appear from car accidents that people think are normal,
Right.
but really they're not.
Right.
Do you see a lot of those?
You do, and as a specialist, I end up seeing more than the family doctors because they're like, oh, he does brain injury medicine, we're going to have him see and see if it's related. But we do see a lot, and the challenge is making sure it's not from other things. For example, someone has a head injury, it might be mild. As you can see, the symptoms are so vague. Are they depressed? Is there something else going on? That's where you have to go through the records and make sure that you can tease out the information and look at the development of that.
In regard to evaluating individuals, how do you determine whether you evaluate them as a pediatric case or as an adult case? So where's the cutoff and how do you go about it?
Each physician's a little bit different. I mean, if you look at the ages, 18 and above, they're adults. You know, you want to approach both the pediatric patient and the adult patient the same. The differences will include whether they're witnessed events or unwitnessed events. For example, pediatric patients tend to be more sports injuries, more they fell, less often car accidents, although that can happen also, or violence, whereas the adults tend to be more on those. And so you should still approach it the same way, still approach your examinations, but you have to keep in mind, depending on the age of the patient, what are reflexes and examination findings that are typical for that age group that are maybe different from the normal.
So if I hear you correctly, you're talking about developmental.
Correct.
Okay.
Right. You need to know developmental milestones. You need to know what they can and cannot do at certain ages. Also, you need to be aware whether there was pre-morbid things. I've had patients referred to me 16 years old or 15 years old after something that happened for a traumatic brain injury, but they had a IEP or basically an individualized education plan where they were getting assistance because of learning disabilities. So you have to keep that in mind when you're evaluating them as well.
Dr. again, I'd like to just ask, I've said moving concussions brought a lot of awareness to people, and as far as professional football players and concussions, they're obviously aware of that, but we often talk in the office about, like, who's educating the coaches from high school football? What's going on with a young guy that's in junior high or high school playing
Sure.
varsity?
Well, when I was growing up, no one was. Over the last 5 years or so, 7 years, what's happened is because of the increased awareness, especially with the NFL players, there was a big push, especially with the state of Michigan, when we first put together a group with all the universities for traumatic brain injury in terms of sports injuries and concussion, that has now been mandated by the state that they have a certain process for evaluating head injury. And what they've done is they've taken away the decision from the coaches to the medical staff. And even at the university level where I'm at, the coaches have no input into the decision making of whether a player can play or cannot play. What happens is if there is a suspicion of a head injury or an event that's witnessed, the first step is they're pulled off, then they're evaluated by a medical professional either on site or through their PCP or specialist office. There's documentation that has to be done, and then there's a return to play protocol that they have to go through. And there's a big consensus, the Zurich consensus that came out with that. And at that time, once they've gone through the steps, then there's a green light whether they can return to play. And again, the coaches will then be able to determine whether they're going to let them play or not. So there's been a focused and a mandated effort to making sure that they go through the process. And for the state of Michigan, you cannot go around it.